Hello and welcome to Know It All, an all-new information and discussion channel about anything and everything. I'm your host, Nicholas Cullen Cooper. We're going to kick off the new channel and the new year with everyone's favorite topic, healthcare reform, specifically focusing on the past, present, and future state of United States healthcare and insurance. Some basics. The U.S. healthcare system consists of a mixture of private and public insurance, the large majority of coverage coming from the private sector. Of the public insurance programs, the two most popular are Medicare and Medicaid. Medicare mostly insures the elderly and accounts for about 15% of all Americans, whereas Medicaid, which insures about 20% of all Americans, is a state-based program intended for the poor. I'm sure you've heard the term single-payer system in reference to healthcare reform, typically with reference to the structure of healthcare in other countries. In the US, Medicare is essentially a single-payer system, which is defined as a system in which all people are covered by one type of insurance, or more accurately, insured from a single fund. I don't plan on going into much detail about the veritability of a broader single-payer system in the US, but I would like to give some background on some popular single-payer and nationalized programs from around the world, particularly Canada and the United Kingdom. Hopefully I can dispel some common myths and misconceptions attributed to these systems, but as you will see, I do not claim to suggest these programs are in any way perfect, nor do I necessarily believe they would be viable systems for the United States. I simply think it is important to understand how these systems do and do not work as we begin to discuss reform in the United States. First up, Canada, which, along with Taiwan, is the only true single-payer system in the world. Healthcare in Canada, known colloquially as Medicare, is mostly free and is about 70% publicly funded, which is actually in parity with some US estimates that say upwards of 60 to 70% of healthcare spending might be publicly funded, despite the relatively large number of people privately insured. Let's talk about some Canadian healthcare myths. The first of which is that Canadians flock to the United States for care because of the inadequacies of their provincial system. An extremely thorough study conducted in the peer-reviewed journal Health Affairs, entitled Phantoms in the Snow: Canadians' Use of Healthcare Services in the United States, quickly disproves these claims. By the way, a link to this paper and all of my research will be posted down below in the description. Phantoms in the Snow found that almost 40% of the US facilities they surveyed reported treating no Canadians, while an additional 40% had fewer than 10. Extrapolating these findings, assuming non-respondent facilities follow a similar pattern, facilities in Buffalo, Detroit, and Seattle, all major metropolitan border cities, saw approximately 640 Canadian patients for diagnostic radiology services such as CT and MRI scans. They also saw roughly 270 patients for eye procedures such as cataract surgery over a one-year period. By comparison, the annual volume for CT scans and cataract extractions averaged about 80,000 and 25,000 procedures, respectively, in British Columbia alone during the mid-1990s. Over a 5-year observation period, Canadian admissions to hospitals in Michigan, New York, and Washington state accounted for only 2.3 per 1,000 total hospital admissions with regard to the corresponding Canadian provinces of Ontario, Quebec, and British Columbia. What's further is that emergency admissions and admissions related to pregnancy and birth constituted about 80% of these stateside admissions. In regard to Canadians seeking treatment at America's best hospitals for specialized treatment unavailable in Canada, Phantoms in the Snow found 6 hospitals reported 15 or fewer elective inpatients or outpatients, 4 hospitals reported 20 to 60 patients, and 1 hospital reported nearly 600 patients, 90% of which were outpatients and many related to proton beam radiation therapy for cancer. Furthermore, the National Population Health Survey of Canada found that only 20 out of 18,000 respondents had gone to the US in the previous year expressly for the purpose of receiving treatment, a number that may even be an overestimate, seeing as the survey did not differentiate services not offered under Medicare, such as dental services or eyeglasses. Another misconception concerning the Canadian healthcare system is that doctors are fleeing to the US to practice. In recent years, this number has declined, with only 169 physicians leaving for the States in 2003, 138 in 2004, 122 both in 2005 and 2006. These numbers represent less than 0.5% of all doctors working in Canada. The truth is, relatively few doctors leave Canada for the US. In fact, the number of doctors in Canada has reached record highs in recent years. A big issue facing both Canada and the yet-to-be-discussed United Kingdom is wait times. If you would like, you can look up average wait times in Canada by province and by procedure in some of the links down below. Wait times are long. That is undeniable. The reduction of these times is recognized as a priority by both the Canadian and UK governments. It's important to note, however, that these wait times are not a symptom of the single-payer system. Our own single-payer Medicare doesn't suffer from the wait time problem, but rather it is an inevitability of budget constraints. Costs are kept low by limiting supply, mostly for elective procedures. To reduce wait times, Canada would need to spend more money. They choose not to. When proposed, there has been limited support for increased taxation in exchange for reduced wait times. That should be enough info for now. It would be impractical to include all of my research in a video intended as a general overview. You can always use the links below to learn more for yourself or ask a question in the comments section, and I'll do my best to answer you. Now, let's take a look at the United Kingdom, with a focus less on myth-busting and more on the examination of the various benefits and pitfalls of a nationalized healthcare system. First, as opposed to Canada, where public money funds private providers, most providers in the United Kingdom are publicly owned and operated. As with Canada, a majority of funds are publicly sourced. The NHS, National Health Service, employs more than 1.5 million people, putting it in the top 5 of the world's largest workforces, together with the US Department of Defense, McDonald's, Walmart, and the Chinese People's Liberation Army. So this is how the NHS is organized, which is frankly not worth the time to go over. All you need to know is that the NHS operates on a devolved system in which Scotland, Wales, Northern Ireland, and England all operate semi-independently, with the former 3 being allocated funds based on a mechanism known as the Barnett formula. The basic pathway to care all over the United Kingdom is as follows. Consider a woman in need of a hip replacement. Once it is agreed upon that she needs a hip replacement, during a free visit to a GP at a practice where she is registered, the GP refers her to a hospital orthopedic department and will prescribe any necessary medication. She may be given a choice of local hospitals, potentially including some private hospitals, and she can make her choice on the basis of waiting times and other criteria which are made available online. She can choose to go to a private hospital directly, but she must pay for her treatment either out of pocket or through private medical insurance if these resources are available to her. She will have an outpatient hospital appointment with a specialist team where she will be assessed and the necessary diagnostic tests will be made. Within 18 weeks, 12 weeks in Scotland, she will be admitted for surgery, but waiting times have fallen markedly since the 1990s. Following the surgery and primary rehabilitation at the hospital, the patient goes home and is discharged to the care of her GP and their team of community nurses. The GP receives a copy of the discharge summary and is responsible for any further follow-up, such as referral to physiotherapy. The patient will not be expected to pay out of pocket for any of these appointments or for the treatment under the NHS. In England, but in none of the other countries, there would be some cost-sharing, out-of-pocket expenses for her outpatient prescriptions. The current prescription charge is a little over £8. Even then, you are eligible for free prescriptions if you are 6 or over, under 16, 16 to 18, and in full-time education, have a certain medical conditions such as diabetes, cancer, Addison disease, epilepsy, and many more. Even if you don't fall under any of these categories, you may still be eligible for subsidies through the LIS, the Low Income Scheme, intended for impoverished individuals and families. Dentistry, optometry, wigs, and fabric supports all operate under the same low fixed cost principle as prescriptions and are all subject to similar exemptions. Now, let's talk for a moment about healthcare expenditure and outcomes, a topic that will be extremely important once we tackle the United States. Health expenditure as a share of GDP was 9.1% in 2013, which was close to but below the EU average. For the United Kingdom as a whole, life expectancy increased between 1980 and 2013 from 73.7 to 81 years, which is slightly above the EU average of 79.9 years. And mortality rates from most cancers and circulatory diseases decreased. However, chronic disease and disability have not declined as much as in other Western European countries. Thus, while individuals live, on average, longer, they do so in relatively poor health. While life expectancy has seen positive increases, the NHS has failed to correct for health inequalities, with impoverished communities suffering from far worse health outcomes. One extreme example is that of the city of Glasgow, where people living in the more affluent areas are expected to live nearly 30 years longer than those living in the poorest areas. This phenomenon is known as the Glasgow effect. If you would like to know more on the NHS, including data on mental health services, hospital bed counts, technology acquisition, wait times, and additional health outcomes, please take a look at the description below, or don't be afraid to ask a question in the comments section. Alright, let's move on to the United States. It's firstly important to understand that the US spends far more on healthcare than any other country. This was true well before the ACA was ever a thing. While it is true that the US, as the world's richest nation, should spend more on healthcare, the reality is that the spending is disproportionate to GDP. So, we know that spending is higher than it ought to be, but what is harder to assess is the why. Some claim it is due to high obesity rates. Opponents argue that the US's low tobacco and alcohol use counteracts these related increases, though. Some say a prevalence of medical technology, accompanied by high prices of use, is to blame. Others claim it is due to the lack of transparency during price negotiations, both on the consumer and provider level. According to the New York Times, consumers, the patients, do not see prices until after service is provided, if they see them at all, and there is little quality data on hospitals and doctors to help determine good value, aside from surveys conducted by popular websites and magazines. Even doctors find it hard to find price information, which makes it hard for them to make intelligent decisions for their patients. Others claim it is due to lobbying. For example, according to the New York Times, only moderate sedation is needed for colonoscopies in healthy people. In other countries, such sedative mixes are administered in offices and hospitals hospitals by a wide range of doctors and nurses for countless minor procedures. However, between 2003 and 2009, the use of an anesthesiologist for colonoscopies in the United States doubled, and payments to these anesthesiologists for colonoscopies per patient quadrupled during that period. The New York Times claims that it is turf battles and lobbying that have helped keep anesthesiologists in the room. What is apparent, however, is that outcomes do not reflect spending trends. Despite high costs, the US does not experience better than average outcomes, often performing worse than countries who spend comparatively less. Let's take a look at some examples. Here we see the disease burden, or the disability-adjusted life year rate, compared to the average. Here are foot and leg amputations due to diabetes in relation to comparable nations. Hospital admissions for preventable diseases, medical errors versus average, obstetric trauma during vaginal delivery versus comparable countries, potential years life lost, general mortality rate, and use of emergency services. It's obviously not all bad. The US is good with cancer mortality rates, and 30-day mortality for heart attacks and strokes are lower in the US than in comparable countries. Wait times are generally low, except in some cases for acute visits. Access to cutting-edge technologies and specialized treatments are also very high. Surprisingly, generic drug prices tend to be lower than the OECD average, though brand name prices and physicians' fees certainly are not. Overall, I agree with the World Health Organization in stating, it is difficult to generalize about the United States healthcare system and, accordingly, hard to draw overall conclusions about its performance. In some respects, it is unquestionably among the best in the world. Yet in other respects, there are significant shortcomings. Obamacare. Dun dun dun! First off, what is it? Introduced in 2010, the Patient Protection and Affordable Care Act, I'll refer to it as the ACA from now on, is an attempt at major regulatory overhaul of the US healthcare and insurance system. When it comes to private insurance coverage, the ACA introduces substantial subsidies on a sliding scale toward the purchase of healthcare for individuals and families with incomes below 400% of the federal poverty level. Also introduced is an insurance requirement that individuals and families have health insurance coverage. If they do not, they pay a penalty unless the lowest cost plan available to them has a premium that exceeds 8% of the person's income. The ACA also establishes a federal and state-based health insurance exchange where competing insurers offer their products to individuals and small businesses. The states have a lot of authority over how they will regulate the insurance market. There's also a requirement that insurers provide a guaranteed issue of a policy to any applicant and to renew that policy. They cannot charge higher premiums based on health status or pre-existing conditions. Exceptions are that older enrollees can be charged up to 3 times as much as younger ones, and that smokers can be charged 50% more than non-smokers. Insurers are also prohibited from placing annual and lifetime limits on the dollar value of coverage. Now for Medicaid. In states that choose to accept federal subsidies, initially at 100% of expenditures declining to 90%, Medicaid coverage will be expanded to individuals and families with incomes at or below 138% of the poverty level. This measure was actually made optional to the states by a Supreme Court ruling. Okay, now Medicare. There is a provision that certain preventative services must be provided with zero copayment. There are reductions of government payments to Medicare Advantage plans. There is the provision of bonuses to Medicare Advantage plans that achieve high quality scores, and formation of a board that will make binding recommendations to contain costs, unless overridden by Congress, if fee-for-service Medicare costs grow more quickly than 1 percentage point above gross domestic product. This all really just scratches the surface. The ACA is an extensive law that would take anyone dedicated study to fully understand. I may be able to answer any questions you have about the ACA that I do not cover in this video, but I would like to focus our attention on 2 things: cost and outcomes. Let's now look at the ACA's effect on healthcare spending and prices. Note that healthcare spending has slowed in recent years. However, the likelihood that this is a result of the ACA is low. The Kaiser Family Foundation states there is a very strong statistical link between business cycles and inflation and national health spending. However, because the effect of economic activity on health prices and utilization is gradual and highly lagged, it is not always easy to discern the relationship by looking just at a single year measures, but that in general, the vast majority, 77%, of the recent decline in health spending can be attributed to the broader changes in the economy. So it's possible that the ACA plays a modest but not overwhelming role in recent slowdowns in spending. Okay, now, finally let's get into what people care about the most: cost and coverage. Firstly, at the time the ACA was being formulated, it was estimated that 43.8 million people, about 15% of the population, were uninsured. 55.9 million had been uninsured for at least part of the year, and 31.7 million had been uninsured for more than a year. Underinsurance, which is insurance that doesn't provide adequate coverage or outcomes, was also a problem affecting an estimated 25 million people. Besides affordability, pre-existing conditions also limited access. As you can see, the number of uninsured has dropped dramatically and continues to do so, particularly with those who are most disadvantaged. No one disputes that the ACA has reduced the number of uninsured by considerable margins. In that sense, it is a success. The pre-existing conditions clauses of the ACA have been particularly popular. Some predictions asserted that the ACA would lead to reductions in employer-sponsored healthcare coverage. This has not happened. This is likely because average employer contribution has risen faster than the average employee contribution for at least 15 years now. The ACA has made little impact. Now, what about cost? First, let's consider the cost to the individual in the form of premiums and deductibles. This figure shows average premium increases for 5-year periods from 2000 to 2015. The first thing you'll notice is that the rate of growth of premiums has slowed significantly compared to the early 2000s. Growth, however, still outstrips earnings and inflation. So the first thing to note is that the ACA is not directly responsible for premium increases, for the rate of increase was in fact higher before its inception. The lower rates cannot necessarily be attributed to the act either. So now we see that premiums have always gone up year after year, in fact at a greater rate than they do now. What is concerning, however, is that the average income has not kept up. Employee contributions to premiums and deductibles amounted to 10.1% of U.S. median income in 2015, compared to 6.5% in 2006. Take a look at these two maps. The first is health insurance premiums as a percentage of median income in 2003, the second, 2011. Yikes. There's also no denying that the ACA has done little to curb the growth of deductibles, as indicated by this chart. There's also the hard truth that as of 2013, the US is still a leader in terms of cost-related access barriers, aka the inability to fill a prescription or visit a doctor due to cost. It's not all bad. The Medicaid expansion, in states that have accepted it, has decreased barriers of entry. As you can see, income eligibility thresholds have dropped significantly for most at-risk groups. The flip side of this is that the expansion is optional as deemed by the Supreme Court, and thus not all in-need citizens have increased access. It is true that many premiums on the exchanges increased by double-digit percentage points in 2017. The good news, however, is that as premiums rise, so do subsidies, in the form of tax credits. This is because the subsidies are not only based off of income, but also tied to the second least expensive silver plan, aka the benchmark plan in your area. Therefore, any increases in premiums is generally offset by increased tax credits. As you can see here, in an example of cities analyzed by the Kaiser Family Foundation, most major markets saw a 0% increase in premiums after applied tax credits from 2016 to 2017. In fact, the only city besides Chicago on the complete list, found below, to have seen any increase was Albuquerque, New Mexico. Of course, not all people qualify for tax credits. Between 15% and 20% of all those shopping on the exchanges do not qualify for subsidies due to income. For these people, premiums will rise substantially in 2017. It is recommended for all of those shopping on the exchanges to shop around every year as opposed to auto-renewing your policy from the year before. The New York Times demonstrates this benefit by comparing the average percent increase of renewing the cheapest plan from 2014 into 2015 versus reshopping for a new plan in the new year. This has remained true in subsequent years. The journal Health Services Research concludes of Obamacare. Overall, research shows that the ACA has substantially decreased the number of uninsured individuals through the dependent coverage provision, Medicaid expansion, health insurance exchanges, availability of subsidies, and other policy changes. However, affordability of health insurance continues to be a concern for many people, and disparities persist by geography, race, ethnicity, and income. All of these changes are certain to ultimately impact state and federal budgets. Speaking of, let's talk for a brief moment about budgets and other secondary economic effects of the ACA. First off, let's talk about some secondary effects. For example, a 2016 National Bureau of Economic Research working paper examined the effects of Medicaid expansion on financial outcomes of beneficiaries. Using credit report data, research showed that the expansion was associated with a reduction of collection balances of as much as $1,000 for those receiving Medicaid. These financial benefits also extend to the society as a whole. A study from early 2015 looked at how expanding coverage to children in the 1980s and 1990s affected long-term finances. The analysis showed that children whose eligibility increased were more likely to go to college, earn higher wages, and pay more taxes by the time they were 28 years old. Conversely, according to the New York Times, it is true that Medicaid reimburses physicians and hospitals less generously, and that it often leaves beneficiaries with fewer choices than a private insurance might. However, it is important to note that the ACA does, in fact, include many cost-saving measures. I'm going to link a very interesting video here and down below that details these provisions. The Congressional Budget Office, CBO, and the Joint Committee on Taxation, JCT, actually produced a report in 2010 stating that the Affordable Care Act would decrease the federal budget deficit. These same organizations, which are strictly nonpartisan by the way, released a report in 2015 stating that, including the budgetary effects of macroeconomic feedback, repealing the ACA would increase federal budget deficits by $137 billion over the period of 2016 to 2015. This brings us to our final segment. In the same report, the CBO went on to claim that repealing the ACA would cause federal budget deficits to increase by growing amounts after 2025, and that the number of non-elderly people who are uninsured would increase by 19 million in 2016, 22 million or 23 million in 2017, 18, and 19, and by about 24 million in all subsequent years through 2025, compared to the number who are projected to be uninsured under the ACA. In most of those years, the number of people with employment-based coverage would increase by about 8 million, and the number with coverage purchased individually or obtained through Medicaid would decrease by between 30 million and 32 million. The Kaiser Family Foundation estimates that 27% of adult Americans under the age of 65 have health conditions that would likely leave them uninsurable if the pre-existing condition protections of the ACA were repealed. About 53% of American households would be affected. These numbers are conservative and likely underestimates. Hospital finances would also be adversely affected if the ACA was repealed without being immediately replaced by a comparable system. A report commissioned by the American Hospital Association and the Federation of American Hospitals shows that a repeal of the ACA would result in a $441 billion reduction in hospital revenue between 2018 and 2026. Of course, as uninsurance rates rise, utilization rates fall, taking into account this reduced utilization and crowding out, which is the movement from commercial insurance to Medicaid and Marketplace at the national level. The reduction in hospital revenue over this period would be about $260 billion. An increase in Medicare DSH payments would also increase revenue, bringing the final loss for hospitals over this period to $165.8 billion. Obviously, these numbers reflect a future in which Obamacare is completely repealed and not replaced by a new, comparable system. This is unlikely, as not only will the ACA prove difficult to fully repeal, but congressional Republicans and President-elect Trump claim to have plans in place for replacement. During his campaign, Mr. Trump released a 7-point plan on this matter entitled Healthcare Reform to Make America Great Again. Let's take a brief look at each of these points. Point 1. Completely repeal Obamacare. Our elected representatives must eliminate the individual mandate. No person should be required to buy insurance unless he or she wants to. This is rather self-explanatory. I would just like to briefly mention that the individual mandate was implemented to reduce costs for all citizens in the long run. Without a mandate, healthier citizens are more likely to opt out of insurance altogether, which forces prices upwards. As prices trend upwards, more and more people leave the market. Also, to a lesser degree, as the and underinsured default on medical debt, an occurrence that is unfortunately not all too rare, the remaining cost then must be covered by increased prices and/or taxation for all. Having said that, there are understandable concerns regarding individual liberty and free market forces in regards to such a mandate. Point 2. Modify the existing law that inhibits the sale of health insurance across state lines. This one is a little less straightforward. This issue has been debated for decades, so there are plenty of opinions on the matter. First of all, it is a little misleading. Insurance can be sold across state lines. It's just that insurance agencies must comply with the laws of the state in which the sale takes place rather than those of their home state. Removing barriers to interstate sales would inevitably undermine states' rights. As the New York Times notes, just as many businesses tend to incorporate in Delaware or credit card companies have headquarters in South Dakota, insurers may end up congregating in whatever state offers the most lenient regulations. This would result in reduced protection for consumers. Furthermore, removing barriers isn't only a matter of licensing. Cross-state insurance sales also involve setting up favorable contracts with doctors and hospitals so that customers will be able to get access to healthcare. Establishing those networks of healthcare providers can be hard for new market entrants. Just because a good, affordable policy is available in another state doesn't mean that you and I would be able to get the network of physicians and the good prices that are available in that other state. Once again, proponents of this measure reference an uninhibited free market as their major motivation. As Mr. Trump's plan states, by allowing full competition in this market, insurance costs will go down and consumer satisfaction will go up. Point 3. Allow individuals to fully deduct health insurance premium payments from their tax returns under the current tax system. This sounds good on the surface. Keep in mind, however, that the tax deductions would come in place of the current tax credits afforded under the ACA. Because it is a deduction and not a credit, this measure would disproportionately benefit the wealthy. Point 4. Allow individuals to use health savings accounts, or HSAs. This one confuses me. The Manhattan Institute in 2014 stated that HSAs, at least for the moment, remain widely accessible on public exchanges. The report finds that, far from becoming obsolete under the ACA, high-deductible plans are widely available. 98% of uninsured Americans have access to at least one HSA-eligible plan. Moreover, these plans also make up about 25% of total offerings on Obamacare exchanges. I can't find any evidence to suggest that this has changed since that report. So I suppose this point is less about fixing the ACA's downfalls and more about confirming the president-elect's support of such plans. Point 5. require price transparency from all healthcare providers. As I've already discussed, many believe a lack of transparency to be a major culprit of high prices and spending in healthcare in the United States. I suspect such a measure would garner widespread support. It is more simply said than done, however. Point 6. Block grant Medicaid to the states. The argument here is that states best know how to properly administer Medicare, as they have more incentives to seek out and eliminate fraud, waste, and abuse, as well as having more insight on how to maximize effectiveness of fund allocation. However, as the Commonwealth Fund notes, current proposals for dramatically reducing federal spending on Medicaid would achieve this goal by creating fixed funding formulas divorced from the actual cost of providing care. As such, they would create funding gaps for states to either absorb or, more likely, offset through new limits placed on their programs. As a result, block granting Medicaid or instituting per capita caps would most likely reduce the number of Americans eligible for Medicaid and narrow coverage for remaining enrollees. Block grants divorce real-life needs from funding formulas and thus usually result in relative funding reductions. The Congressional Budget Office estimates that such a plan would indeed reduce federal spending by about $1 trillion over 10 years, but at the cost of denying 14 million people access to insurance. Okay, and on to his final point, point 7. Remove barriers to entry into free markets for drug providers that offer safe, reliable, and cheaper products. This is great in theory, but once again, easier said than done. I suspect there is generally widespread support for such a measure. An analysis by the Rand Corporation claims that all of the Trump proposals decrease the number of insured, increase out-of-pocket spending for consumers enrolled in individual market plans, and raise the federal deficit compared to the ACA. Okay, that about covers it for now. Once again, I'd like to stress that you can find further readings down in the description below, or if you're so inclined, leave a question or comment and I'll get back to you as soon as I can. Thank you so much for watching. If any of you made it this far, it'll be a miracle. Further videos on this channel may be less research heavy and more discussion and concept heavy. In the future, the channel will also feature contributions from friends and colleagues of mine. If you have any suggestions or would like to contribute to this channel in the future, please contact me. Bye-bye.